Good evening, everyone. I'm Angelica Nogueira, Chair of GYN LACOG. On behalf of LACOG, I would like to show our gratitude for having you all here with us and for MSD for this meeting support. Atom Connection was born last year in the GYN LACOG group, and it's growing fast. In 1 year, several other LACOG tumor groups are working on these necessary Latin American interactions. We hope this educational initiative can help us to overcome barriers to treatment and clinical research in our area. Once again, thank you all who are part of it. And focusing on our meeting today, it's a very important moment for gynecologic cancer patients. So many advances have occurred recently, and today we're going to have the opportunity to discuss treatment option and treatment sequencing. We have never had this opportunity to treat options in advanced endometrial cancer, cervical cancer. So we have divided the discussion today in two blocks. We will start with endometrial cancer, and then we are going to move for cervical cancer. I'm going to chair part one, endometrial cancer, and I have the honor to have here today with us Professor Brian Zlomovitz, who is a medical oncologist from Miami and who is my friend and one of my favorite medical oncologists in the US, and also Glauco Baiocchi, who currently is the president of the Brazilian group of gynecology oncology, our EVA group. And we have a lot to cover today. Let's start working. And recently we have had impressive data in advanced endometrial cancer first line. I'd like to invite Professor Brian to start covering the topic emerging data and its impact on first line treatment of advanced or recurrent endometrial cancer. Welcome, Brian. Thank you for joining us.
Great. Well, Angelica, thank you so much for having me. It's really an honor and privilege to be included in this conference, and I only hope that next year we could do this in person, so thanks for having me. So we have a lot of information to go through. We have about 15, 17 minutes, so there's a lot of information to go to, so I don't want to spend too much time speaking, but I'll have two talks. The first talk is about the first line treatment of endometrial cancer and all the great changes that Angelica was alluding to. And then after a case review, we'll give a second talk about second line options. Treatment for endometrial cancer definitely is a moving target. It's constantly changing. It started at some of the data. The immunotherapy has been going on for years, but first line data I'll go through that was presented this year at the SGO, and we'll go from there. In addition to being a gynecologic oncologist at Mount Sinai Medical Center in Miami Beach, I also serve on the GOG Partners Group as a uterine cancer clinical trial advisor. Here are my disclosures. So as mentioned, we're going to first go into the first line treatment of advanced or recurrent endometrial cancer. I briefly want to review some of the statistics for endometrial cancer. Many of you may know this, but I think it is important to review. The numbers are going up. This is the United States numbers. Of all the cancers that we treat, it's one of the few that actually the number of cases and the number of deaths are increasing, as opposed to some of the great progress we're making in some of the other diseases that we treat. Most patients are treated with surgery alone. However, 1/3 will have high-grade or advanced stage disease, and this represents the unmet need. Increasing incidence, increasing mortality, and there's also it's anticipated to outnumber the deaths of ovarian cancer soon in the United States. One of the nice things about the treatment is that we're really going away from one size fits all. We're going away from one treatment for everyone, and we're really able now to divide these cancers into different subtypes based on the molecular profiling. This has been a great advantage, starting at the Cancer Genome Atlas data that was published in about 2013, and we made great strides since then in order to offer better treatment options for our patients. Gone are the days of just looking at tumors through a microscope. Now we're doing more molecular profiling. Even from early diagnosis, when they're just diagnosed, we do testing for mismatch repair proteins, estrogen receptor status, P53, and other common markers, so we have this information right from the start. This is a classic view of what we used to do: just grade, myometrial invasion, histologic subtype, LVSI, and stage and age, and we're progressing from here. The benefits of doing this molecular profiling include better prognosis. We estimate progression-free survival and overall survival by molecular class, a better sense of risk assessment. It's a predictive factor. We know which patients need more treatment, and we're also learning about which patients we could actually de-escalate or decrease the treatment options. And also, the molecular profiling gives us an idea of which of these cases are due to hereditary mutations. Lynch syndrome is the most common, and which patients really need to be further tested. As I mentioned, the prognostic role. Here's several different studies looking at unselected cohorts. The different bars represent the different molecular classifications. I'm not going to get into it too much because this isn't the focus of our talk. However, the POL-E molecular classification, those patients do very, very, very well. Moving down, those patients with deficient mismatch repair proteins, I'll go into this more, but in summary, they're more amenable to immunotherapy. Non-specific molecular profile is third, followed by the most aggressive endometrial cancers, those with p53 mutations that represent the more aggressive, the most aggressive forms of endometrial cancer, and those that lead to the most mortality and morbidity due to this disease. Based on the molecular profiling, we're happy to announce that very, very recently, the FIGO, the Global Classification of Endometrial Cancer, this group is led by my friend Jonathan Barrick, and the key here, we're not going to go through all the staging, but the key here is that they not only push aggressive histologic subtypes with any invasion into the second stage, but as we go through this, we'll see that they've added molecular classifications to the staging system. This is a tremendous step, going away from the traditional histologic factors that we've seen and the clinical spread, and it's giving us a better idea, again, of how to treat our patients. I mentioned POL-E mutations have a good prognosis, intermediate prognosis, the mismatch repair deficient tumors, and those with a non-specific molecular profile, and the most aggressive being those with the p53 abnormality, and they portend to have a worse prognosis. When the molecular classification is known, it's actually inserted into the staging. For example, you could see here from the second bullet, when there's a p53 more abnormality, it's not just stage 3, it's stage 3 with a mutation in p53. Really a great progress in what we're doing and what we're learning about patients. And we really know that staging allows us to better universally treat patients and universally come up with a prognosis. And incorporating molecular classifications, again, is a great stride. And this is really a global initiative. Here's just one more slide showing the POL-E mutations in stage 1A would do very much better. This is actually the best prognostic endometrial cancer, and the p53 would represent a worse prognostic indicator. So, when we talk about advances in treatment, we like to first, in the United States, refer to the NCCN guidelines, and I want to go through these very quickly. Right now, the preferred primary adjuvant therapy is cisplatin plus radiotherapy, followed by carboplatin paclitaxel. Other preferred regimens we've learned is just chemotherapy, carboplatin paclitaxel, and most recently, this was added about pembrolizumab and dostarlimab in the first-line NCCN guidelines. Very, very, very advantageous for our patients because we're allowed to give them, and insurances are paying for this in the frontline setting based on these NCCN guidelines. Now, it's interesting, and I must say, carboplatin and cisplatin currently in the United States are on a shortage. We can't even get it. Now, I don't think that's a global problem. I think it's more of a access to care regulatory issues here, but we're working through this issue. But right now, it's checkpoint inhibitors are easier to find for our patients than carboplatin, which represents a sad time in our medical care for our patients. Recurrent disease options are listed here, and again, I just wanted to show the NCCN guidelines. Chemotherapy for first-line recurrence, and I'll go through this in more depth. A lot of studies ongoing, which I'll go through. Second-line therapies. There's no long list, but as I tell my patients, A long list is not necessarily a good thing. That means there's not one or two good options. And then we'll talk about some of the immunotherapy data in this setting. Hormonal regimens is something that I've been studying a lot in this disease setting, and these are an option. We're looking at it in the first-line setting, but particularly in the second-line setting as well. Now let's go through the data, where we were and where we're going. Traditionally, paclitaxel and carboplatin became the standard of care treatment options when we did GOG 209, led by Dr. David Miller. Here we can see that there is a comparable efficacy, but the side effect profile, as you know, was much more favorable with paclitaxel carboplatin than it was with the triplet taxanes, adriamycin, platinum regimen. This study made carboplatin and paclitaxel the standard of care for this patient population. Based on the work of Amanda Fader, there's a lot of interest in looking at HER2 overexpression. Here in the US, we define it as 3+ by IHC, or if it's 2+ by IHC, we do follow-up FISH testing to determine if it's HER2 overexpressed or not. This study, which is a phase 2 study, showed that in those patients with HER2 overexpression, the addition of trastuzumab portended a better prognosis than those patients with just carboplatin and paclitaxel alone. In a subset of analysis of patients restricted to stage 3 and 4 disease, the earlier treatment, the benefit of trastuzumab was actually better than those on the right treated with recurrent disease, showing that the earlier you give it, the better it works in patients with endometrial cancer with HER2 overexpression. So this is in the NCCN guidelines, and we'd like to include this in our treatment regimen as well. We talked about now the Cancer Genome Atlas and how that's changed what we do. How that comes into play with different treatment options is it's helped us divide what we call hot tumors, or those tumors that are amenable to immunotherapy alone, versus cold tumors, those that just are amenable to immunotherapy. It doesn't mean we don't give immunotherapeutic agents. It means we need to do something to help turn the cold tumors hot. Combination approaches is something that we're looking at in the first line, and I'll talk about the individual studies. But when we talk about the immune checkpoint inhibitors and their activity, we're learning that they may work well with anti-angiogenic agents, lenvatinib we'll talk about, with PARP inhibitors, and I'll talk about a couple of trials looking at that, as well as immune checkpoint inhibitors with chemotherapy. This is a second-line study, but I wanted to talk about the combination of anti-angiogenic inhibitors and checkpoint inhibitors here. This is lenvatinib plus pembrolizumab, a study 775 led by Vicky Macker, and this led to the full FDA approval of lenvatinib plus pembrolizumab over traditional chemotherapy in the second line. I know this is the first line talk, and we'll talk second line later, but I wanted to talk about this combination here with a statistical advantage in overall survival. Very, very a tremendous benefit for our patients. Not only to see the improvement, but one of the things that I've been working forward in my career is to see what we can do to get rid of chemotherapy and its associated toxicities in patients with endometrial cancer. And then here's the rationale for the chemotherapeutic approach, and then we're going to dive into this more. Chemotherapy with immunotherapy can increase tumor cell death, increase expression of tumor antigens. It has the myeloid-derived suppressor cell depletion and the T regulation depletion, as well as homeostatic proliferation of T cells, leading to a synergistic effect. So the question here, will chemotherapy and immune checkpoint inhibitors replace chemotherapy alone in all comers? Now here's a series of 3 studies, 2 of them have reported out, that looked exactly at this question. Randomized phase 3 trials, chemotherapy plus placebo versus chemotherapy plus immune checkpoint inhibitor. On the upper left, we can see the ATTEND trial. The ATTEND trial is looking at paclitaxel carboplatin plus minus atezolizumab. And this study has completed accrual, but is not yet read out, and we're hoping for results soon. RUBY on the upper right and GY018 on the lower middle are looking at chemotherapy plus minus dostarlimab for the RUBY trial, and chemotherapy plus minus pembrolizumab in GY018. First, I want to go through the data of GY018, and I want to make sure we finish on time. So very briefly, this is a randomized phase 3 trial, 1-to-1 randomization. This was 2 parallel studies in one. The 2 primary endpoints was the PFS in the pMMR group and the PFS in the dMMR group. Those were the endpoints. It was a positive trial, and in the end, they unblinded the patients, so overall survival wasn't looked at. But let's take a deeper dive into the data. In the dMMR population, dMMR, deficient mismatch repair proteins, there was a benefit of adding pembrolizumab in the first-line setting, stage 3 or 4A, stage 4B, or recurrent endometrial cancer, with a hazard ratio of 0.30. This hazard ratio, as you know, is comparable to that in SOLO-1 with PARP inhibitors in BRCA-mutated patients. It's that much of an impact. In those patients with pMMR or proficient MMR tumors, there was still a difference in outcome, however not as dramatic. Here the hazard ratio was 0.54, representing a 46% decreased chance of recurrence in these patients. The dMMR, it's clearly an advantage and clearly should be implemented. pMMR, we need to get longer follow-up data to determine. Similarly, in the RUBY trial, GOG 3031, again, similar study, 1-to-1 randomization. However, the primary endpoints here was PFS by the investigator and OS, not as much of a robust look into the pMMR patients. This study, one of the differences was it had a longer follow-up than GY018. The results here, PFS in the dMMR setting, again, tremendous impact. Hazard ratio of 0.28, similar to the 0.3 that we saw in the GY018 trial. One thing that I want to highlight here, if you look at the upper left of each Kaplan-Meier curve, during the time of chemotherapy, the lines overlap. This, we're not sure, it may be a sequencing, but this suggests that giving checkpoint inhibition with the chemotherapy may not be the advantage, but it's the follow-up maintenance immunotherapy that works. I mentioned the follow-up here was much longer than the follow-up as seen in the GY018 trial. The PFS in the overall population, not the pMMRs, but overall, was a hazard ratio of 0.64, representing a 36% decreased risk for recurrence. The overall survival was looked at in RUBY, hazard ratio of 0.3, again in the dMMR patients, and hazard ratio of 0.64 in the overall population. However, the maturity here was only 33%, so we need to continue to look at it. Moving forward, we're looking at PARP inhibitors in this setting. I mentioned in GOG 3031, or RUBY Part 2, they added in dostarlimab in the part of the maintenance. This is completed accrual and is yet to read out. DUO-E is a very similar trial looking at the addition of olaparib and durvalumab, a checkpoint inhibitor, in a similar population. And while we haven't seen the data, this is a press release that showed that this is a positive trial. However, as we all know, the devil's in the details, and we really need to see the data. Hopefully it will be presented in a meeting in the near future. Other ideas, getting rid of chemotherapy altogether. LEAP-001, looking at lenvatinib pembro versus carboplatin paclitaxel in the first-line setting. Again, the study's complete. We're anxiously awaiting it to read out. And this is a study that I'm leading globally, Keynote C93, which is looking in a dMMR setting, pembrolizumab alone versus chemotherapy. In colorectal cancers, we've seen an advantage in this population, and we're hoping this will hopefully read out sometime in the next year or two, and hopefully another mechanism of getting rid of chemotherapy in the first-line management of this disease. We're also looking at immunotherapy in the adjuvant setting. Now imagine if we put IO in the adjuvant setting, then we're going to need to readdress all the other strategies in the first line if we put IO first. Here's 2 studies doing that, GY020, giving with radiation, and a study that I'm leading for the GOG, chemotherapy plus minus pembrolizumab in high-risk patients in the adjuvant setting. The one on the left completed accrual in August of 2022, results are pending, and we're pending results on B21. Quickly, other strategies we're looking at MDM2 inhibitors These are ongoing studies that are about to start, are ongoing in patients with p53 wild-type tumors. We know that that endometrial cancers overexpress MDM2, and by blocking these, it can lead to cellular dysregulation, increased death. It's a key negative regulator of p53. MDM2, therefore, is a promising target for anti-cancer development, and this is a randomized study we're leading from the GOG, looking at an MDM2 inhibitor, navtemadine, versus observation in a maintenance, eventually in a maintenance setting, to see if it could help patients do better and live longer. Similarly, selinexor, or nuclear transport inhibitor, is being investigated in the maintenance setting. One study was done looking at all patients. While the curves were separated, it wasn't enough to get FDA approval. Subgroup of patients with wild-type p53, you can see here much more of a benefit, leading to an ongoing trial, hopefully a regulatory approval trial, looking at the p53 wild-type patients with selinexor versus placebo. And HER2, finally, we talked about, is also being looked at in the first-line setting in those patients with overexpression. That's what I have for my first talk. Thanks for your attention, and I look forward to the case presentation.
Thank you so much, Brian. It was an outstanding presentation. We are going to have time to discuss after the clinical case. So now I'd like to invite Professor Glauco Baiocchi. I've already presented him, and he's going to present us a clinical case on endometrial cancer. Initial disease, Glauco.
No, it's an
advance.
Let's go. Thank you so much thank you so much for the introduction. I'm very happy to be here, and congrats, Dr. Slomovitz, for the great presentation and concise presentation. It's very difficult to put every data together. Thank you so much. So I'll present a case here. It's a 65-year-old woman with BMI of 28. She had just diabetes type 2 and family history of breast cancer at 68 years from a maternal aunt. So this patient was nulliparous with menopause at 49-year-old, and she was admitted at August 2020 with a history of vaginal bleeding for 4 months. She had, during the pelvic exam, the physical exam, she had a vaginal bleeding at the sternal cervical os, and she also had a post-con appearance not suitable for office biopsy, so she went to a stereoscopy and biopsy. She also had the CA-125 of 12. The biopsy showed an adenocarcinoma serous type with the immunohistochemistry of p53 mute, mimetic repair proficient, L1 cam positive. She also had a HER2 positive, and it was not available to do the pole status sequencing. This is the magnetic resonance showing a deep myometric invasion, and she did not have any sign of extrauterine disease at this time. Then she went to surgery. She had a surgical staging in October 2020. She had a TH-VSO and sentinel lymph node mapping associated with systematic pelvic and para-aortic lymphadenectomy, laparoscopic assisted. She was part of a protocol called ALICE trial. And then the surgical time was 300 minutes with no surgical complication. And the final pathological report showed a serous histology, tumor size of 4 centimeters, presence of lymphovascular space invasion, myometric invasion of more than 50%, one positive lymph node for macrometastasis in the para-aortic region. She then, after she had advanced treatment with carboplatin and paclitaxel every 3 weeks for 6 cycles, and after the chemotherapy, she had external beam radiation, including the para-aortic region. She coursed with adverse events, grade 1 neuropathy, grade 2 fatigue, grade 2 diarrhea. And during the surveillance, after 21 months of disease-free survival, She had we found in the CT pulmonary nodus, and was confirmed by the PET CT. The one of the nodes have a higher of SUV 3.8 in any other findings. That is the case for us to discuss. So it's a what is the what now, Dr. Zlomovitz? What would you prefer to do with this patient?
Yeah, so it's a great case, and I would say that it's definitely was treated correctly in the first line setting. You know, here in the U.S., while some people are using the Herceptin in these 3+ HER2 overexpressing tumors, it's definitely not universal standard of care. And as I quickly showed, we have a trial here, GY026, that's evaluating implementation of HER2 blockade versus Taxol/Carbo alone. So it's still standard of care not to. You know, the recurrence in this setting, I think that, you know, pembrolizumab lenvatinib is definitely a reasonable option where there's good data in that setting. You know, at some point I'd want to do a HER2 blockade, but, you know, I think pembrolizumab is a reasonable option. Now, for those of you who went to the ASCO meeting this year in Chicago, and I'll have some slides of this in my second talk, there was some newer data presenting looking at trastuzumab deruxtecan, which is an ADC over HER2. And in these 3+ tumors, the response rate was over 80%. I mean, unheard of, really unheard of for recurrent endometrial cancer, particularly the serous type. Very small study, extremely small study, really a signal showing study, and then we need to do follow-up studies now to see if we can incorporate it into the standard of care. But some component of HER2 blockade, I think, is going to be crucial for these patients. Right now, given all the resources we have, I'd probably go with pembrolizumab lenvatinib, and then if she fails that, some traditional chemotherapy like adriamycin or we put paclitaxel.
Just discussing, I'd like to discuss the patient when she had initial disease, to start the discussion if it's possible. If the patient is stage 3, completely resected, HER2 3+, would you consider at this moment to give immunotherapy based on, this patient was included in the Ruby trial, for example. Also, the patient was included, Cyrus was included in the GY18. Would you move immunotherapy earlier, or would you consider trastuzumab when the patient was stage 3 based on the Amanda Feder data? I think I would consider that at that time to give chemo combined to trastuzumab. Initial disease, not here.
You know, I agree completely. I think that's a question that we talk about in our tumor boards and our disposition conferences now all the time. You know, we'll have to see what the FDA says about approval of in the pMMR setting of chemotherapy plus the checkpoint inhibitors. The data in GY018 is a little bit better than the data in Ruby. However, the follow-up is shorter. So as we all know, the longer you follow up, the difference may not be as robust. But I like what you said. I do. I think Amanda Feder's data on trastuzumab in these HER3 3+ tumors is compelling. Particularly, she showed in the newly diagnosed patients, it probably works a little bit better than the recurrent patients. So if this was my patient, given the current standards, I would go with carboplatin, paclitaxel, and trastuzumab. And what that also does, I'm sorry, and Dr. Monk and I talked about this earlier in the day, what that also does, it reserves pembrolizumab lenvatinib for the second-line setting. And as we know there's a survival advantage compared to traditional chemotherapy. So when I treat my patients, I always like to have, I don't treat them I give the best agents first, but I also like to have things in reserve. The second line, in that scenario, the second line setting I would give is pembrolizumab lenvatinib.
Would you add the trastuzumab for the adjuvant treatment?
I would if I had the opportunity, Glauco. I think it's a small trial, only 61 patients, but there was an overall survival gain, and the data we have, these patients need more treatment than chemotherapy alone. The patient with stage 3 and serous carcinoma, they really need more systemic treatment. But now it's interesting that for the first time we have options for the patient at the metastatic setting. I would go for pembrolizumab as well. So, but this patient could have the opportunity to be exposed to. If we had the opportunity in Brazil, we cannot use trastuzumab in the advanced setting here, not in the adjuvant setting. Okay, I'm just discussing possibilities. In our country, it's not approved, but pembrolizumab would be a good option, and we hope we can have the deruxtecan soon in the country. We know that there are movements to bring the deruxtecan in the second line soon, based on the destiny presented, just discussed by Dr. Brian. So we have good options for them. I would go for pembrolizumab as well.
Great. Well,
great. We need to move for the second. Yes.
Thank you so much.
Thank you so much, Glauco, for this great case. I'd like to invite again Professor O'Brien to continue his presentation, and now he's going to discuss treatment approach on the advanced endometrial cancer following prior systemic therapy.
Okay, can everyone hear me okay?
Perfect.
Great. So, no, thank you for that. I thought that was a very nice discussion, and it really leads in nicely to when I talk about some of the second-line treatment options here. Second-line treatment for endometrial cancer definitely does represent an unmet need that we need to come up with better treatment options. Chemotherapy, here's just some of the options that we're looking at. Chemotherapy right now, 15 to 16% response rates. mTOR inhibitors, one area that I've investigated, 4 to 7% by themselves. Combined with hormonal therapy can be up to 24%. Megace tamoxifen, pure hormonal therapy, 19% response rates. Bevacizumab, 13%, and cediranib, another targeted therapy, 12.5%. These numbers are low, and we need to do better. Here's a brief summary of the hormonal therapy. A lot of these are the traditional GOG trials. While there's a response rate that I discussed, even in the grade 1 tumors, maybe even as high as 33%, we could see here that the PFS desperately needs better efficacy. One study that's not listed here is the NCIC, a Canadian study of letrozole alone, showing a 9% response rate in this setting. So combining endocrine, and I alluded to this a little bit, combining endocrine therapy and targeted therapies are a strategy that we've been using to help overcome hormonal resistance. Different strategies that have been investigated and are being investigated include mTOR inhibition. Everolimus is the oral asset, the agent that we've been using. PI3 kinase inhibitors, alpelisib, and CDK4/6 inhibitors, which is one area that has been investigated by Mansour Mirza and his group, but with somewhere that we're actually trying to exploit further as we go forward. There's a new class of hormonal agents called selective estrogen receptor degraders, which we've started doing some trials in. Fulvestrant has been available, but now we're looking at giredestrant and some of the others. And then we have SERMs, which have been around, tamoxifen, raloxifene, tormethine, that we're continuing to investigate. So as far as mTOR inhibitors, here's a phase 2 trial that we looked at with everolimus and letrozole. This is work that I did with, at the time, my mentor, Rob Coleman. We looked at this combination in a phase 2 trial, 2 sites. We found a complete response rate of 26%, partial response rate of 57%, which really demonstrated active disease in this population. What we know now is that it's more active in the endometrioid tumors, which makes sense because that represents a group of tumors that are more likely to be ER overexpressors and hormonal responsive. And we did do a translational component to this trial, showing that those patients with beta-catenin mutations were more likely to respond to this combination than those without the beta-catenin mutations. We're still not just limiting the regimen to those with a beta-catenin mutation. However, it's something that we look at and we can sort of predict a better response in that population of patients. Based on that phase 2 trial, we did a randomized phase 2 trial comparing everolimus versus the traditional tamoxifen and progestin. We did this in the GOG. And here's the results. Everolimus, similar response rates, which again, with cytostatic agents, and I'll show you another study, cytostatic agents as compared to cytotoxic agents, we would expect a similar response rate. However, the progression-free survival in all comers, 6.3 months versus 3.8 months. Now, what we found in this study, 1/3 of the patients had no prior chemotherapy. 2/3 had prior chemo, 1/3 had no prior chemotherapy. And we looked at that population of patients, the PFS 21.6 months versus 3.9 months, and the tamoxifen megase 6.1 versus 3.2. The bottom chart here is very compelling. Again, cross-trial comparison. We can't do it, but we always do these anyway. In the chemo-naive patients, everolimus letrozole had a 53% response rate, which you can see compares favorably to GOG 209, the study that I presented in the first session, 51%. But the progression-free survival was 50% more, 21 months versus 14 months, cross-trial comparison. But again, compelling data that says maybe in those patients that don't want chemotherapy, that have hormone receptor-positive endometrioid tumors, that giving everolimus letrozole is a reasonable option. And I've done it, not as a first option, but in my patients that have refused chemotherapy, I've given everolimus letrozole, and similar to the study, I've seen good prolonged responses. CDK4/6, as we know, regulates the transition from G1 phase to S phase of the cell cycle, representing a reasonable target. We can see here that the CDK4/6 is involved with cyclin D progression to retinoblastoma and the E2F. By using a CDK4/6 inhibitor, you block the genes involved with cellular proliferation. We know that CDK4/6 inhibitors are approved. There's 3 approvals here in the U.S., palbociclib, ribociclib, and abemaciclib in this setting. All three of these inhibitors have been approved in the first and second line settings, and even abemaciclib is approved in the adjuvant setting. There's several studies, 3 studies actually, that have been done in the U.S. looking at CDK4/6 inhibitors in endometrial cancer. The first study was done by Colon Otero, actually endometrial and ovary cancer, and they found that there was the endometrial cancer patients had a 45% response rate and a long PFS, one study demonstrating activity. And here's further looking at the data. The median PFS and overall survival was 5.4 months and 16 months, respectively, showing that CDK4/6 inhibition does have activity not only in endometrial cancer, but in low-grade serous ovarian cancers as well. Our friend Panos at the Dana-Farber did a similar trial looking at letrozole and abemaciclib, another CDK4/6 inhibitor, showing that they had a partial response rate of 30%, stable disease of 43%, with an overall response rate of 30%. Again, demonstrating activity in this setting. All of the responders had endometrioid tumors, as we would suspect. Finally, the last study that's been done was a study done by Mirza, Mansour Mirza, I mentioned earlier. This was an ENGOT trial, randomized phase 2 trial, 1-to-1 randomization, placebo letrozole versus palbociclib letrozole. Primary endpoint here was investigator-assessed PFS. And here are the results. On the left, we could see the Kaplan-Meier curve. The PFS was 8.3 months for the investigational arm versus the standard arm of 3 months, with a hazard ratio of 0.56. Now, not reported in his presentation, but in discussion with him, the response rates were the same. Again, cytostatic agents don't necessarily have a better response, but a longer duration of response. Disease control rate was also higher in the experimental arm, 63% versus 37% in the letrozole alone arm. Based on this data, we're doing a phase 1 trial, a first-line trial of CDK4/6 inhibitors plus letrozole, lerociclib, it's an asset made by EQRx, versus letrozole and placebo, to see if, in fact, this second-line option can be moved into the first line. Here's the data that we were talking about and we're very passionate about and very excited about. Presented at ASCO this year, Destiny Pan-Tumor 02. It was several tumors being investigated, not just endometrial cancer. As mentioned, trastuzumab deruxtecan is an ADC, 3 components. It has the anti-HER2, which will bring it and attach it to the cell. It has topoisomerase 1 inhibitor, which is interesting because the activity here, as we talked about, shows that topoisomerase or topotecan may work in this setting. We've never used it, but the problem there, we thought maybe it was a lack of efficacy. Maybe it was just a lack of the ability to get into the cell, which we're able to do with these ADCs. This keto and antibody-dependent conjugate is having a cleavable linker. Once the cytotoxic, once the kill is attached to the cell, we need to let go so it gets into the cell. The Pan-Tumor 2 study presented looked at a series of tumors: cervical, endometrial, ovary, other sites outside the GYN tract, biliary, pancreatic, bladder, and other tumors. Open-label, multi-center trial. And here are some the characteristics: 40 patients in the GYN tumors. And here's the evidence. Look at the complete response rate and a partial response rate and stable disease. 57% overall response rate in endometrial cancers. 57% in the second-line setting. Again, in HER2 overexpressing solid tumors, representing clearly a signal that we have to further exploit. Even in the cervical cancer patients, 50%, and Brad may talk about that later. Ovarian cancer patients, 45% response rate. Again, demonstrating phenomenal activity that we need to look at further. Now, this is where where the data really gets interesting. In the IHC 3+ patients, similar to the case that was first discussed, 85% response rate in the second-line setting, at least. Amongst all comers, 57%, IHC2, 47%. Biomarker predictive, it's a prognostic and predictive marker, but 85% are numbers that we've never seen before in the recurrent setting. Overall, well-tolerated agent. And there was also a previous study in carcinosarcomas, which demonstrated a response rate of 55% in this population of patients. Really remarkable data that we have to look at further in those HER2 overexpressing tumors. Another asset looking at TROP2 ADCs, another marker that's overexpressed in several endometrial cancers. 96% of grade 3 tumors have it overexpressed, and a 65% chance of uterine serous carcinomas have it. Overexpression is a poor prognostic signal. This is a study that was preliminary data presented also at the ASCO meeting. Overall response, we had about 32%, 33% in this population of patients treated with sacituzumab govitecan, an ADC against TROP2. Again, representing another drug agent that we should further, encouraging activity means that we should further investigate it, maybe in the recurrent setting sometime in the near future. Median PFS was 5.7 months, overall survival was 22 months. Another asset that we're looking at, and again, I'm going to make sure we finish on time, WEE1 inhibitors. Adavosertib was investigated in those tumors with p53 mutated backgrounds. WEE1 is, we know that cell cycle checkpoints slow down the cell cycle, allows time for appropriate DNA replication, and prevents progression. Cells with T53 mutations lose their G1S checkpoint, leading to early entry into the synthesis phase, increases replication stress. And WEE1 is a key regulator of G2M checkpoint. Inhibition leads to dysregulation and mitotic slowing down of catastrophe. Here's one study that was done with a WEE1 inhibitor. Again, adavosertib, 27% response rate. Disease control rate was 56%. Again, in this set of tumors that's very aggressive with a poor prognosis, very exciting numbers and representing an area that we need to further investigate. While WEE1 inhibition results in anti-tumor activity and may remain a viable treatment option, the therapeutic window currently is narrow, with the most common treatment-related serious adverse event were neutropenia and sepsis, something we need to work out and sort of decrease if we're going to advance these agents further. Now, quickly, I just want to talk about, and we'll just discuss these in the cases so we'll have time, but look how the landscape's changing. Ruby and GY018 were positive. What if LEAP is positive, the first-line lenvatinib and pembro? Where will we go from here? Will we give chemo with checkpoints or go away from it totally, knowing that lenvatinib has some toxicity? And what about the C93 trial, DMMR patients? If that's positive, can we eliminate chemotherapy in those DMMR patients? If LEAP is negative, then we'll stay with Ruby and GY018, except again, the DMMR positive patients, maybe those patients will be amenable to IO alone. And what about in the, that was for the DMMR patients. What about in the PMMR patients? We're not sure, again, about IO in the first-line setting. We talked about that extensively. This is where we have some clinical trials, and we're very excited. And our first option for our patients is putting them on clinical trials. And then in the adjuvant setting, we talked about this. What if we push IO into the adjuvant setting? Then first and second line is wide open. If we use IO first, what will we use in the first line? Maybe it'll be the selinexor asset. Maybe it'll be hormonal-based therapies or an MDM2 inhibitor. The second-line therapy, hormonal agents, again, selinexor, lerociclib. And again, the key here is what are we going to do with trastuzumab deruxtecan? Very exciting data moving forward, which way we're going to go. And hopefully it'll again be standard of care. This is my place in Miami Beach. Thank you for giving me the time and inviting me, and I'm really excited to be here, but more excited about the future of endometrial cancer and the drugs we have to treat this disease. Thank you.
Yes, amazing time. The first time we are discussing sequencing of treatment of endometrial cancer, and so many questions we have. I think we have a second case. Who is going to present? Brian?
Hello, Angelica. Thank you for your introduction. I'm trying to share my screen, but can you see it now?
Perfect, Valeria. Thank you.
Okay, thank you so much. I'm here from Buenos Aires, no beach, no sea, but anyway, we are here with an 81 years old patient. Her body mass index is 25. She has a long story that began in 2011 with radical hysterectomy with pelvic lymphadenectomy. She was on a stage 1A, FIBO 1 endometrial cancer. At that moment, we tested estrogen receptor. It was 90%. And she left in control after surgery, and she has a free survival disease of 90-60 months. In December 2019, she has a lung relapse. She was totally asymptomatic. She was very reluctant to face chemotherapy. So at that time, we decided to treat her with metotrol acetate, 160 milligrams per day. And although Brian told us that the PFS was less than 3 months, here she has a very good PFS, 12 months. She was completely asymptomatic, and in a control, in January 2021, she has a peritoneal relapse. And at that time, we convinced her to treat with carboplatin with 6 cycles. And we perform the chemo, the immunohistochemistry that we could have, that it was 50-53 negative, HER2 negative. And also we have of the 4 proteins with immunohistochemistry, she was non-staining MLH1 and PMS2 negative. So she was MSI by immunohistochemistry. We didn't have the possibility to have more data, so we couldn't do it. It's a public hospital in Argentina. And she was PS0 and ECOG0. She was in very good state, and now she's 81. And so after a completed carboplatin with a PFS of 8 months, she progresses. And so to sum up, our patient in 2011, she performed surgery and she was in control for 1960 months. And in December 2019, she has lung relapse treated with hormonal therapy. After a PFS of 12 months, she has peritoneal relapse with paclitaxel, 6 cycles, and she was MSI, and she has a PFS of 8 months. So now here is what we are going to do in our patient. She is 81 years old. She has a performance status 0, ECOG 0. and she has MSI. So, of course, you have to take in account the previous lines of therapies, the mutational status, the histology, comorbidities, and fitness for therapy. And in this patient, we decided to start with pembrolizumab for 3 weeks. This was September 2021. Here you have the basal scan. Here you can see the disease that she has at the peritoneum. And after 3 months of cycles of pembrolizumab, she really has a very good response, a partial response, a reduction of the mass here that you can see at the CT scan. And after 6 months of therapy, she was in complete response, and she continues in complete response till June 2023. So the idea was to share this case to you, and of course to discuss with Brian and Angelica what you think about the case and if you will treat the patient in the same way. Thank you so much.
Thank you, Valeria. We cannot treat differently because she's on complete response. We cannot offer anything better. Could we, Brian, offer something better perhaps?
Yeah, no, I mean, really true. The right treatment, giving that combination, the IO inhibitor is the right thing to do in this setting, and you demonstrated that. Now, one of the questions we're going to have when the LEAP trial comes out, because the LEAP trial, remember, is pembrolizumab versus chemotherapy. It included all patients, pMMR and dMMR. If we look at the patients with dMMR in that study, and if they in fact beat chemotherapy, the question we're going to have is, does lenvatinib add something to the immune checkpoint inhibitor in the dMMR patients? And we don't know the answer. It's going to be a cross-trial comparison. So I agree with what you did. In the second-line setting, the data is clear. There's no doubt that you have to give single-agent IO. But what we don't know, can lenvatinib add to that? I wouldn't do it. Not only is there no proven efficacy, but let's not forget about the side effect profile that we see in lenvatinib, which is tolerable, and we're getting better at it, but it's still not as well tolerated as IO alone. But,
and I think that in this case it was easy because it was she was 80-something years old, and I think that the decision was not so difficult. But sometimes we have the question, would lenvatinib add something for this mismatch repair deficient patients? And I don't think we're going to have the final, based on a phase 3 trial, we won't have this answer, but we need to choose based on the performance status, volume of disease, and if we think that it adds. If it comes to first line, it will be even more difficult because this is the decision will be even more difficult because we have to give the best treatment for the patient. Regarding the hormone treatment, Brian, would you consider the combination with cyclin inhibitor for this patient, considering that palbociclib is not so difficult to give compared, for example, to abemaciclib, which is difficult to give? She's 80 years old. Would you consider the combination in first line?
Yeah, so we're going to be investigating that. I mentioned the Laracyclib letrozole study in the first line versus letrozole alone. So I think CDK4/6 inhibitors would be active in a patient like this. If she ever does recur, I think that's an option for her. Even though she had progestins in the past, I do think either an mTOR inhibitor with an AI or a CDK4/6 with an AI would be reasonable. One of the things that's interesting and that we are looking at, you mentioned, Angelica, like what if she got IO in the first line, what would you do here? In these patients with dMMR who are treated with immunotherapy, this may be the subgroup of the patients that we have to look at IO after IO. Can we, in fact, retreat patients with immunotherapy? Now, there are some trials looking at it. One trial that we're doing through the GOG, it's a podium trial, GOG 3038, which is the checkpoint inhibitor made by Incyte. I forget the name, but we're combining it with an anti-TIM and an anti-LAG immune modulators, and we're seeing if the triplet can, in fact, overcome the immunotherapy resistance that the tumors have. We're also doing something similar with TIGIT. TIGITs. I think that's another active target in combination with IO, TIGIT inhibitors. So there's a lot of options for this patient. It's always good to have a lot of options. She's HER2 negative, but when we look, one thing I want to mention, when we looked at the Destiny data, they did local testing, but then they sent in the tumors for central testing, and a subgroup of the tumors were actually HER2 zero, and some of them did respond. So we don't know what the level of HER2 we're going to need, even in that setting. Excellent care, right treatment. There's no second guessing, as Angelica mentioned, no second guessing the checkpoint that was given because she had a durable CR. But if she recurs, I think there's a lot of options, and not only that, a lot of tolerable options. Again, like the CDK4/6s or the mTORs. And then finally, selinexor seems to be an active agent, at least in the maintenance setting in this population, as demonstrated in the subgroup of the SIENDO trial. So that's a nuclear transport inhibitor as well.
We have a question from the audience focusing on the HER2 question. Patient with metastatic disease, first line, both HER2 positive and mismatch repair deficient. So considering, would we go for trastuzumab combined to chemo or chemo combined to immunotherapy? Which decision for first line? I have my question. I have my answer. I'd like to hear you.
That's a good question. It's unusual. First of all, it's unusual, right? Because in general, most of the HER2 patients are the uterine serous high-risk histologies, and most of those are pMMR. However, don't make that assumption, because there are some uterine serous that are dMMR, so they still need to be tested. This is an easy answer. You have to go with a checkpoint inhibitor. Hazard ratio of 0.3 or 0.28 are numbers that we haven't seen. Some of the best data that we've seen in gynecologic oncology. Again, slightly better. If you look at the SOLO-1 data with PARP inhibitors in BRCA patients, it's even lower hazard ratio than that. So the data with trastuzumab is good, but the data with checkpoints in the setting is out of this world. So, Angelica, I would imagine you were going to say the same thing.
I totally agree. I think Amanda Father is beautiful data, but only 60 patients. It's a phase 2 trial, and I would go for immunotherapy. A huge overall survival gain for this mismatch repair deficient population in first line. And now we have the Ruxtecam that you are going to have it in the US. It's going to take longer for us. But at least in Brazil, the approvals are getting faster, and I think that we're going to have this approval based on this beautiful, expressive data. I think that we're going to have this approval soon. So I think that I would keep HER2 blockage for second line for sure in this mismatch repair deficient patient. And one last question from the audience to move for cervical cancer. What's the time between one first systemic treatment? What's the time frame to indicate pembrolizumab? 6 months, 12 months to go for to consider second line?
Yeah, so that's a great question. So when we looked at the GY018 and Ruby, we allowed those patients to be enrolled in those studies, even if they got carboplatin and paclitaxel, but if the disease-free interval was 6 or 12 months. And then they could get treated on the carboplatin and paclitaxel and IO. Personally, I would go right to pembrolizumab lenvatinib in that setting, because they demonstrated that they can recur with chemotherapy. You can always go back to chemotherapy, but pembrolizumab is the 775 data did have an overall survival advantage. But I wouldn't criticize someone for going to carboplatin and paclitaxel. One last point I want to mention from the last patient when we talked about dMMR and would you give carboplatin and paclitaxel and checkpoint. Remember, there's 2 trials, C93 and Domenico, which may actually get rid of chemotherapy in that setting in the dMMR patients, which would be really cool.
I hope they're going to be positive. The rationale is strong for them to be positive. Do you have any comments, Valeria, Glauco, because we need to finish the first session to move for the cervical cancer session?
Well, I have two questions for you. In this patient that you are in complete response, how long will you go for immunotherapy? Because we have some data in first line for Pembro, 20 cycles, in the Ruby, 3 years. What do you think about this second-line immunotherapy alone in this patient?
Yeah, my first answer is yes, but that's not really giving an answer. Remember, checkpoint inhibitors, it's not the constant exposure, it's the education of the cells. So, for one thing, yes, definitely don't continue them indefinitely. But we don't know the answer about, 2 versus 3 for checkpoints. We don't know the how long we should keep PARP inhibitors in maintenance therapy. These are answers that we don't have, but in my practice, I'm sort of going by the book. Most of my patients are on Pembro because it's easier to get, and I'll go with 2 years. And I've had some patients on it that recently have stopped. But dostarlimab, I'll go with 3 years. But again, not because I have great data to support it, but just that's what they randomly chose in the trials.
Thank you very much.
Treatment duration is very important, especially for us from low and middle income countries. I would go for 2 years. If she's in complete response, I would stop Pembro at 2 years. Based on the limited data we have focusing on time frames. Again, we have 3 years in the first line trials for dostarlimab. It's so bad because it increases so much the cost of treatment. We should focus on shorter durations. We need trials focusing on shorter versus longer durations. This is very relevant for us to help us incorporating those important drugs for patients. Ryan, thank you so much for this beautiful discussion. It's always so great to hear your experience. Valeria, thank you. Glauco, you are brilliant. It's an honor to be with you.
Thank you so much.